Everyone, happy Friday. Thank you so much for joining us. According to the World Health Organization, 1 in 6 couples struggles with infertility. Just because you're struggling with conception doesn't mean that your dreams of having a family can't come true. There has been an increased interest in vitro fertilization or IVF. IVF is a medical procedure where an egg is fertilized by sperm outside of the body in a laboratory. And then the fertilized egg or embryo is transferred to a woman's uterus with the goal of establishing a successful pregnancy. There can be a lot of confusion when you're starting this journey. That's why we're so glad to be joined today by Jessica Mans of Explaining IVF. Jessica is an embryologist, IVF plus infertility educator. So during this live, we're going to discuss IVF, the embryo grading, embryo transfer process, and Jessica's services. So I saw Jessica has joined us. Let's go live. Oh, here are. Hi, Jessica.
Hi, how are you?
How
I'm
are you? Thank you so much for making the time.
thank you so much for having me on. I'm really happy to be here.
We have never ever had an embryologist join, had IVF doctor, we had a functional medicine doctor, people focusing on infertility or IVF process, but people explain the beginning, but then nobody really explained the whole embryologist side, the laboratory side. So thank you. Thank you.
Absolutely.
Before we start, tell us a little bit about yourself, your background, like how you became an IVF expert and an embryologist.
Okay, perfect. I'm kind of one of those people who I've known what I've wanted to do for a really long time. I first learned that I wanted to be an embryologist back when I was in high school, so 16 or 17 years ago now. And I had to do a project about what I wanted to be when I grew up, and that's how I sort of stumbled. I don't know what happened there. I got disconnected. I hope it doesn't do it again.
It's all good. It's okay.
Okay, so anyway, yeah, I've known I wanted to be an embryologist for a long time now. As soon as I learned about what it was, I did everything that I could basically to get into the field of embryology. So I got my undergrad, my bachelor's degree at the University of Pittsburgh, and then I got my master of biomedical science at Colorado State University. And the program actually specialized in assisted reproduction, so IVF, and that's how I got my basic skills. And then I had a job outside. As soon as I graduated, I got a job and worked in a clinic for 4 years. And now I am a traveling embryologist. So I travel to different clinics and I get to help out as needed with the different procedures in the lab.
So for people who don't know, what is an embryologist and how can they help a person during their conception journey?
Sure. An embryologist is primarily focused on the in vitro fertilization process. So we are kind of involved in everything from the time the eggs are removed from a woman's body to the time that an embryo is transferred back into a woman's body. So we do everything in between. So the egg retrieval process, the insemination process, watching the embryos develop and grading those embryos, determining which are suitable for transfer. We do embryo biopsy, which is something for pre-implantation genetic testing or PGT. We do embryo freezing, thawing, and then embryo transfers, and then a lot of stuff in between. But that is the basis of what we do. So we handle everything from the egg retrieval all the way to the embryo transfer.
You basically make the magic happen.
Yeah, I like to think of it like that.
It's totally magic if anybody who have not seen like on YouTube or video of how how an egg and sperm how the egg gets fertilized. I've seen videos and I felt it's literally like magic. And obviously the embryologist does that magic and a skill really matters too.
Yes, there's a lot of training involved.
So what made you realize like a resource like explaining IVF was necessary?
That's a great question. So, in the lab that I worked at for 4 years, the embryologist called patients with their updates. And it was just over and over again where I was talking to the patients on the phone and they were asking great questions. But I kept thinking to myself, why are these people spending so much money and time and investing so many emotions into this process and not having any idea of what's happening? you're getting this phone call and you're waiting for this phone call, but you have no idea really what's happening to your embryos. So, and there's information online, but a lot of it is very technical, and there's a lot. So my goal was to take all of that information and along with my experience and just break it down into, little tidbits that were a little bit easier for people to understand. And I wanted them to see what was actually happening inside of the lab, so they had a better idea of what was going on with their eggs, their sperm, their embryos.
It's much needed, much needed. I gave a sort of a high level explanation of IVF on top of the live, and then as an expert, what is IVF? How do you explain it? And what can a couple, expect when they enter this process?
Oh, perfect. That I love talking about this. So, IVF stands for in vitro fertilization, and in vitro actually means in glass, although we actually use plastic, but the name came from in glass fertilization. So it's the opposite of in vivo. So fertilization inside the body, it's outside of the body. So what happens is a woman will administer medications, and those medications will stimulate multiple follicles in her ovaries to develop. And the hope is that in each of those follicles that are developing, the eggs inside of them are also maturing. Eggs go through a process called maturation, and they need to reach a certain level in order to be fertilized. So the hope is that those medications allow for multiple eggs to mature instead of just one, which is what normally happens during a menstrual cycle. But you want to have a lot of eggs available because not every egg that is retrieved always makes an embryo. So they'll take the medications. Usually it's about 8 to 12 days or so. And then after some monitoring, the doctor will determine if she's ready for her egg retrieval. At that point, she'll take a medication that's called a trigger injection. And the trigger will trigger ovulation to occur. But we want the egg retrieval to occur right before ovulation. So we want those eggs to be really mature, but we don't want ovulation to happen yet. Because if ovulation happens, then we can't retrieve those eggs in their follicles. They'll be lost. So right at the time of the egg retrieval, the doctor will go in with a needle. Patients are normally not awake for this. Mm-hmm. So the doctor will go in with a needle, and the needle has a little vacuum attached to it, and they're able to actually kind of aspirate or suck up the fluid inside of those larger follicles. And the fluid goes into a tube. And the tube goes to the lab, so to the embryologist, who looks at all the fluid and finds the eggs. So we find the eggs, and then the extra fluid can be discarded. But those eggs are put into a separate dish where they're kept safe. And then what we do is we kind of just trim them a little bit, because eggs, when we retrieve them, they're not just little round eggs like what you might think of. They're actually surrounded by all of this cloud of cells called cumulus cells. So what we do is we actually trim a little bit. It just makes them easier to find, to count, to maneuver, And then at some point during that day, a couple of things can happen. So the day of your egg retrieval is what we call day 0 in the IVF lab. And if you're having your eggs frozen, your eggs would be frozen that day. If not, your eggs would be inseminated that day. And we have 2 types of insemination that we do. One is called conventional or standard insemination, or sometimes it's just called IVF. And that's when eggs and sperm are placed into a drop of media or fluid overnight. And the hope is that the sperm will travel to the egg, and one sperm will fertilize each egg. The other type of insemination is something that we call intracytoplasmic sperm injection, or ICSI for short. And what ICSI is where you take one sperm in a needle and you inject it into each mature egg. The difference between the two, aside from the actual processes, is that eggs are actually graded for their maturity before they undergo ICSI. They're not graded for their maturity before they undergo conventional insemination. Mm-hmm. So what we see sometimes are lower fertilization rates with conventional insemination, because all of the eggs that are retrieved are put into the dish with the sperm. But with ICSI, only mature eggs are inseminated. And again, eggs have to be mature in order to be fertilized properly. So one of the other things we would do before ICSI is we would clean the rest of the eggs, and we would grade them based on their maturity. So that's day 0. Then we leave the eggs and the sperm, or the eggs that have been inseminated, in the dish overnight, and we look at them the following day to see if fertilization occurred. If fertilization occurred, that means that the eggs are now fertilized eggs, or zygotes, so it's what we call them. We determine if they're able to move on and further in development. So on average, we expect anywhere from about 50 to 80% of eggs that are inseminated to fertilize properly. So those that do fertilize properly are kept in culture, or that fluid, that cultured media, for a couple of days, and they're given some time to grow. Some clinics We'll look at the eggs 2 days later. That would be, they'll look at the embryos 2 days later. That'll be day 3. And some clinics like to do day 3 observations. Some will do day 3 transfers. Other clinics wait and they don't look at them at all on day 3. But normally they will check them on day 5. So that's 5 days after the egg retrieval procedure. And on day 5 is when we can start doing embryo grading. If you're doing a fresh embryo transfer, we can do a fresh embryo transfer on day 5. We can also do PGT, so the biopsy for the pre-implantation genetic testing, and then we can also do freezing on that day. So that's a normal IVF cycle. But another thing too are embryo transfers. So if you have an embryo that's frozen, we can also thaw the embryo and then transfer it as well.
So, I mean, this question I didn't prepare in advance, but I'm just wondering, like, is there any point to do the conventional IVF versus you just do ICSI? Because it sounds like the success rate is way higher. Is there any point to even do the conventional one?
A lot of the times why people do conventional, and there are 2 main reasons. One could be just a personal preference or maybe some kind of religious reason. But the second is the cost. So ICSI, at least before, was not covered by most insurance companies and it was an out-of-pocket cost. So a lot of people did elect for conventional insemination. And again, mostly though, it's a personal preference. Maybe it's a way of trying to stay as natural as possible with the cycle because it is a very unnatural process overall. So yeah, I think that a lot of it is very personal or maybe religious, but the cost is also, I think, a factor as well.
You kind of answered my question a little bit because my next question is on a basic level, like what is an embryo exactly? Like when do you actually count like the embryo being an embryo?
Yeah, that would be as soon as fertilization occurs is technically when it becomes a fertilized egg or a zygote. And that's really when it's considered an embryo because at that point it possesses the DNA of both the sperm and the egg. And it actually starts going from that one cell, dividing into 2 cells, and then so on and so forth. And that's how we all begin. So technically an embryo would begin on day 1 as soon as fertilization occurs. We just don't often think of an embryo until it's, a little further along in development.
Yeah. How are embryo frozen? You mentioned like some embryo, you rethaw it, like the frozen process and like what can, ensure their viability?
Yeah, great question. So when embryos are frozen, they undergo a process where they actually have water pulled from their cells. And we do this through a specialized culture or a specialized fluid. And it's called a vitrification media. So we freeze embryos through a process known as vitrification. So it's very fast. There was an older method, but it was a lot slower. So now most clinics do vitrification. And embryos are moved through some media. And what that media does is it pulls water out of the embryo cells and it coats them with something called a cryoprotectant, which protects it while it's frozen. So the whole process takes roughly anywhere from about 8 to 10 minutes. And then the embryo is actually put onto a device called a cryo device, and it's plunged into liquid nitrogen. And the embryo, it's most of the time they survive. About 95%, if not more, embryos actually survive the process. And what we see sometimes is embryos that are maybe poorer in quality often won't survive. And that's just because some cells are damaged in the process. It's just, some cells might not take up enough cryoprotectant. They might not release their water. So ice crystals might form, which could damage some of the cells. So if an embryo has less cells to begin with, they might have a higher chance of being more damaged than, say, an embryo that has a lot of cells. But that's the basic process. And embryos can remain frozen in liquid nitrogen indefinitely.
Oh, wow. What about the thawing process? How does the thawing process could potentially impact the viability of the embryo?
Great question. The thawing process is pretty much the freezing process in reverse. So the embryo goes from that liquid nitrogen, which is about negative 196 degrees Celsius. So very cold, yeah. And we actually put it directly into a warm thawing media. And the embryo in this thawing media, the cryoprotectant is actually removed from the cells and water re-enters the cells. So what we see then is once that embryo gets then placed into its culture or media, which goes in the incubator, over about 2 to 4 hours, we actually see that embryo start to re-expand again. And that's because that water's re-entering the cells and the embryo can then progress in its development. Because when it's frozen, no development occurs. All activity, cellular activity is halted. There are a couple things that, can happen during the process. Again, there might be some reason why embryos just don't either take up enough cryoprotectant or get rid of enough cryoprotectant. If water forms during the freezing process or if there's still water left in the cells, ice crystals can form, which can damage the cells. Of course, there's always a risk of technical issues, but I say that only because it's a small possibility. But embryologists are very well trained in manufacturers of these different fluids and media. They have specific instructions. It's based on a lot of research about how long to keep the embryos in the media. Embryologists should know exactly what to do just based on those instructions, and by following them, that there's really nothing that they can do to save the embryo if something were to happen, as long as they're following the instructions. But typically it's something we notice it's sort of intrinsic with the embryo, meaning that something's not going right inside of the embryo itself.
That makes a lot of sense. A lot of reassurance as well.
Yes.
What is the embryo transfer process?
The embryo transfer process is where we actually take an embryo that's inside of the IVF lab, so inside of a dish. It can either be fresh, meaning it can be from a couple days after the egg retrieval procedure, or it can be thawed, meaning it was frozen before and we thawed it. So the embryo, either way, would be sitting inside the IVF lab, inside of an incubator, inside of some media. And we take that embryo and we load it into a specialized catheter. And that catheter then gets inserted through the cervix and into the uterus. Everything is normally done on an ultrasound, so the doctor can see exactly where the tip of the catheter is. And right whenever it is right in position, the doctor can actually plunge the fluid that contains the embryo into the uterus. After that, the catheter is removed. Normally it's flushed out to make sure the embryo did come out. Every now and then an embryo will stick inside the catheter, but that's okay. We just reload it and we repeat the process, and it doesn't affect success rates. So that's good. And then from there, you are pretty much released, and then you come back normally about 9 to 11 days later for a blood test, which will determine whether or not embryo implantation has occurred.
Is there any advantage to have like a fresh embryo versus frozen thawed embryo?
There are mixed studies out there about it, so I can't give you a definitive answer. Some say that fresh are better. Some say frozen are better in terms of their success rates. But a couple things to keep in mind. If you are doing PGT, you need to do a frozen embryo transfer because it takes about 2 weeks to get those results back. So in that case, you wouldn't be able to do a fresh transfer. And then for some women who have they're at risk for something called ovarian hyperstimulation syndrome, or OHSS. A fresh transfer is actually not recommended because of the hormone levels being out of balance, basically. So it's advised that they wait and then do a frozen embryo transfer cycle later.
You mentioned the embryo grading earlier. Like, what is embryo grading?
It's a question I get asked a lot. Embryo grading, embryos can be graded really at any time, but what we commonly see are that clinics grade embryos at the blastocyst stage of development. So what that means is that embryos all start as that one cell, that fertilized egg. And then from there, they undergo something called cell division or mitosis, and they divide. So one cell divides into two. Those two cells then divide into four, and so on. By day 3, what we expect to see are around 8 cells, give or take, in that embryo. But then by day 5, we hope to see over 100 cells in the embryo. But in that time, the embryo goes through a lot of morphological changes. So we have grading systems that we use to record basically what an embryo looks like. And there are 3 criteria for it. The first is the embryo stage of development. The second is the appearance of its inner cell mass. And the third is the appearance of its trophectoderm. So the stage of development actually starts to occur a little bit before the expanded blastocyst stage. So let me kind of back up a little here. So on day 3, we normally see about 8 cells in the embryo. Around that time, the cells will actually start to clump together and they'll form something called a morula. And from there, in the morula, a small cavity or a blastocele will start to form. At that point, the embryo actually enters the blastocyst stage of development, and that's when this grading can kind of start. So once this cavity forms, but it takes up less than half of the embryo space, we call it an early blastocyst. And a lot of clinics will maybe call that EB, or perhaps they'll call it a 1 for its stage of development. From there, as that cavity begins to grow, in size and starts to take up more than half of the embryo space, it becomes known as a blastocyst. And sometimes that's recorded as a B or a BL or even a 2. From there, once that cavity takes up 100% of the embryo space, we call it a full blastocyst. At this point, the embryo is actually still the same diameter, though, that it was from the beginning. It hasn't actually grown in diameter, but that cavity has gotten bigger as those cells continue to divide. So once it the cavity takes up 100% of the embryo space, then we call it a full blastocyst. So that could be represented maybe as FB or a 3. And then after that, the embryo actually does start to grow in diameter. So what happens is the cavity is growing, those cells are still dividing, and that shell, it's called the zona pellucida, that surrounds the embryo. It actually came from the egg too. That surrounds it actually starts to thin out under the pressure from the growing embryo. And so once that zona starts to thin out, the embryo enters the expanded blastocyst stage of development. So that is sometimes represented as XB or EXB or a 4 on the stage of development scale. And then a small hole will start to form inside of the zona, the shell, and the embryo will begin to hatch from that small hole. Yeah, at that point, it becomes known as a hatching blastocyst. You might see it as HGB or a 5. And hatching is important. The embryo actually has to hatch in order for implantation to occur. So hatching is a good thing. And then eventually it will fully hatch from its shell. So then at that point, it's an embryo with no shell surrounding it. It's a fully hatched embryo. So you might see that as HB or HDB or a 6. So the 1 through 6 scale is something called the Gardner scale. So again, the 1 is the early blastocyst stage, and it goes all the way to 6, which is fully hatched. So if you, for example, see an embryo that has a 4, that means it's an expanded blastocyst. So that's the first letter, or the first part of embryo grading. The second is the appearance of the inner cell mass. So once the embryo reaches that blastocyst stage of development, it starts to develop 2 different cell lines. Some of those cells will ultimately become the fetus or the baby. The other cells will begin to become the placenta or the non-fetal tissues. So the part of the embryo that ultimately develops into the fetus, that's called the inner cell mass. And if you look at a picture of an embryo, it sometimes looks like a clump of cells that kind of sits off to the side of the embryo. And what we do is we can grade that on an A, B, C, sometimes D scale. Some clinics also use numbers for this, like 1, 2, 3, but what I commonly see the most is like A, B, C, or A, B, C, D. So A would be like a textbook perfect inner cell mass. It's very round, it's compact, it's beautiful. B would mean that it's there, it's fairly compact, it's average looking, which is perfectly fine. And then C and D would obviously be below average. D might be degenerate or non-existent. And then the third part of embryo grading is the trophectoderm. So those are the cells that line the shell of the embryo, and they ultimately develop into the placenta and the non-fetal tissues. And those are also normally graded on an ABC, sometimes D scale, with A being the best. So A would mean that there are a lot of cells, they're very uniform in appearance, there aren't a lot of gaps, it would be textbook perfect at that point. B would mean average, so a lot of cells are present, maybe they're fairly uniform, might be a couple of gaps, but still look pretty good. And then C would be below average, a lot of gaps, not uniform. And if your clinic uses a D scale, it usually means degenerate or non-existent. So, and every clinic has different protocols for what they'll consider suitable for transfer. Some clinics might say absolutely no CC embryos or absolutely no embryos with a D grade in them. So just to give an example, if you have a 4 AB embryo, then you've got an expanded blastocyst. It's got an above average or perfect inner cell mass and an average trophectoderm. So that's sort of where that comes from.
Oh my God, it's so complicated.
It's a lot of information. Yes, I asked about it a lot.
Then people also do, you mentioned a PGT testing, and then so they do that testing, I guess, then once the embryo is being tested, and then also based on the grading of the lab, then they will pick one embryo for the transfer if they decided to PGT.
Right, exactly. So we would want an embryo to be genetically normal or perhaps a low-level mosaic, depending on what your clinic's protocol is for mosaic embryos. But yes, you want a genetically normal embryo. And then typically from there, the criteria is to choose the embryos that developed first and are also the highest grade. Those have the highest chance of success.
That makes sense. What causes the embryo transfer to fail? And then how can you cope?
Great question. So when we think about an embryo transfer, we kind of have two two buckets that we can put everything in. We have the embryo bucket and the uterine bucket. So there are kind of two things to consider. With the embryo, you want to consider, was it genetically normal? Was it, or, if it wasn't tested, perhaps it was genetically normal. And then you also want to think about its stage of development and its grade. So if it was maybe an embryo that was a below average grade, it still can absolutely result in a successful outcome. But embryos that are poor grades do tend to sometimes have lower chances of implantation, especially when they're untested. And then the other thing to consider is the uterine environment. So, was there something going on in the uterus that maybe caused the embryo to not implant? And there are a lot of diagnostic tests now that are available to determine maybe if there was a polyp or a fibroid that maybe was interfering with it. Was there maybe something called endometritis, which is sort of an inflammation or an infection inside of the uterine environment? So there are a couple of things there as well. And then, of course, there are times when there's really no way to tell whether it's the embryo or the uterine environment. Sometimes they're just unexplained failed transfers. And those, of course, are the most frustrating. But yeah, when we think about the reasons why embryo transfers don't work, those are the two things that we kind of need to think of. And those are good questions to ask your doctor if an embryo transfer fails. Like, do you think it was the embryo, or do you think it was something uterine? Do you think it was maybe just a one-time thing? Would it be different the next time around? What can we do to change things next time, basically? And how to cope. It's coping with a failed embryo transfer. It's difficult because it is a loss. I mean, we definitely have to we need to know that it is a loss and that it should be treated as a loss. And that means that you need to go through the grieving. And everyone's different. Some people grieve a little more, some people grieve a little less, but grieving is absolutely okay to do following a failed embryo transfer. Reach out for support if you need it. If you have a partner or family members that are aware of your embryo transfer, reach out for support. Don't be afraid to talk to a licensed professional if you need help as well, coping with the loss. And of course, reach out to your doctor. Let your doctor know how you're feeling and see how you can, what you can do moving forward, at least, to kind of take your time to grieve, but also see how you can change things moving forward to hopefully have a better outcome.
We have one question related to this topic. I'm 41 years old. What is the cause of IVF failure and reoccurrence miscarriage during frozen embryo IVF? Also, what leads to bleeding 2 days after 5-day embryo transfer and proceed during 10-day period?
These are good questions. I'm probably not the best person to answer about the bleeding. I would probably talk with your doctor about that. I just don't possess the knowledge to answer that. The cause of IVF failure. So we sort of talked about that recurrent miscarriage during frozen transfer. So again, we sort of talked about could it be the embryo? Is the embryo abnormal? We do tend to see an increase in abnormal embryos after 35 years of age. So that kind of seems to be the age where we see a higher incidence of aneuploidy, meaning embryos that are genetically abnormal. So I don't know in this case if the embryos were genetically tested or not, but it's possible that they could have been genetically abnormal. I also don't know their grades. That's also a potential reason. And then also the uterine environment, like we talked about. And there are some tests out there that can be done. There's something called like a recurrent pregnancy loss panel or test that some clinics will do. But every clinic's a little different. So I recommend reaching out to your doctor and saying, what can we do to prevent this from happening again? Or what can we do to optimize our chances? Because there are options available, but it depends a lot on your medical history. And there are just a lot of factors to consider. So I think that's a good question to have with your doctor.
You almost answered my next question. My next question is like, what are some questions to ask after an embryo transfer?
Yeah. You mean after a successful or a non-successful?
Well, I think you just pretty much answered a non-successful. Like, let's talk about like, if you had a successful transfer, what should you be aware of? What should you talk to your doctor about?
Yeah. Good question. I guess either way, even if you just don't know yet if it's positive or negative. Sure. So some questions. So your doctor, before you leave your clinic after your embryo transfer, someone should go over your instructions and also over your restrictions. And so some of the things that are often recommended are walking, don't stay on bed rest, but walk, don't overexert yourself. Try as hard as you can to avoid stress, even though it's really difficult at that time. But some questions to ask are if there are some things that you like to do. For example, if you like to run and you run every day, you can talk to your doctor about like, is this okay to do? Or is it okay if I'm going away for the weekend? What can I do? What can I not do? So it's just really good to have clear instructions about what you can and cannot do following your embryo transfer, because you want to be able to optimize your chance of success, basically. So you can also ask your doctor what signs to look out for, whether they be reasons to call your clinic or just common early symptoms. You can talk to your doctor about what medications or supplements, for example, like a prenatal vitamin, are recommended and what you should be doing. But I really think the most important thing is just knowing your instructions and sticking with them. And if it's something kind of strange, like on Tuesdays I do hot yoga or something, is that okay? And know before you do it. And that way you feel comfortable and you can, you'll be more comfortable going into it knowing that your doctor said this is okay to do.
Absolutely. Absolutely. Is there any way someone can work with you?
You mean in the lab or like with my Instagram?
Both.
Um, well, since
The reason I asked that question is that, because the skill of embryologist really matters. I mean, you obviously know your stuff. So if someone wants to work with your clinic, knowing that you will be handling, their eggs, their sperm, their embryo, they might want to know that. And obviously, if someone wants to get additional consultation, I also want to find out, like, how can someone work with you?
Yeah. I mean, I think that if anyone really wants to reach out to me, the best thing to do is send me a message on Instagram. That's where I do a lot of my communication with people. And, I'm always happy to answer questions, and we can work together any way you want to there. Since I'm a traveling embryologist, it's a little bit more difficult because I go to different clinics. So it's hard to know where I'm going to be at any given time. But, people can always reach out about that too. And if you have any interest in becoming an embryologist, I'm happy to point you in the right direction about where you need to go or what you need to do, and get you in contact with people who can help you with that. Definitely.
Anything else you'd like to promote?
I don't think right now. There was something really exciting though that I did want to share. So the American Society for Reproductive Medicine just recently changed the definition of infertility to be a lot more inclusive for people that it wasn't really inclusive for before. So what we're hoping to see now are some changes in earlier diagnosis, maybe people getting better treatment that weren't before, or earlier treatment than they were before. I'm a huge proponent of staying proactive with your fertility. So I think that's really exciting. But the main thing that I always just recommend to people is just always advocate for yourselves. If you have questions, please ask, and ask me or ask your doctor, or get the information that you need, and don't be afraid to ask questions, because that can be the difference between a successful and a failed cycle. And so I'm not really promoting anything. I'm just promoting advocacy, I guess.
This is amazing. Thank you so much for sharing your knowledge. I think we'd absolutely love to invite you back, because there's like so much more to talk about, like even just from the perspective of testing, right? PGTA testing, or like other type of testing that needs to happen. And there's still many more like process or steps we haven't really discussed in detail. So if you're open to it, I would love to have you back.
Oh, absolutely. I'm always happy to educate anyone who wants to hear me talk. So always happy to educate about IVF and anything associated with it. So I would love to come back. Definitely.
Wonderful. Thank you so much.
Thank you so much. That was great.
Great weekend.
Okay, you too. Thank you.
Bye.
Bye.